Now I'll turn the program over to my co-chair, Dr. Shannon Whaley, who will introduce our next set of speakers.
Good morning, all. It's nice to be in a room where we can see each other, isn't it? Last time we were in that gigantic room. This is lovely. Thank you for the introduction, Kathy, and welcome to our first, last, and only session for today. I think we've done this a number of times. We're delighted that you've come today. And our next speaker follows really nicely on Danielle Berman, on Dr. Berman's talk, on this topic of nutrition education. As Danielle shared, and many of us know, nutrition education is one of the cornerstones of the WIC program and really sets WIC apart from some of the other nutrition assistance programs. So we're eager to learn more, as much as we can as a committee, about nutrition education. We have gleaned whatever we can from the published literature because we have access to that. And today we're really lucky to have another presenter come speak to us. So Dr. Jamie Dollahite is a professor of community nutrition at Cornell University. She is the Director of Food and Nutrition Education in Communities, as well as the Director of the Northeast Regional Nutrition Education and Obesity Prevention Center of Excellence. Dr. Dollahite leads the state EFNEP program, that's the Expanded Food and Nutrition Education Program, and she works closely with the New York State Office of Temporary and Disability Assistance to provide leadership and technical assistance to SNAP-Ed. For the last 25 years, she has worked in the area of nutrition education for low-income audiences designed to prevent obesity and chronic disease. And I'm really delighted to welcome her here today. So with that, Dr. Dollahite, I welcome you to the podium where there you are. Thank you and welcome.
Thank you so much. I want to thank the committee for inviting me, and particularly I want to thank Dr. Berman for the basic information she's given us about the WIC Nutrition Education Program. It's a good lead-in to what I'm going to be talking about today. I do want to tell you that I have a bit of a frog in my throat this morning. I brought some water up here with me, but I hope I don't have to clear my throat too many times. Okay, so I didn't practice this. So here we go. Okay, so I'm going to begin today with a bit of an introduction, and I'm going to review just a few old studies from WIC, just to set the stage, not the current stuff that you just heard about. And then I'm going to talk a bit about nutrition education across USDA programs, nutrition education programs, the similarities and differences, because I want to focus on EFNEP, SNAP-Ed, and WIC throughout my presentation. And then I'll spend some time talking about more recent studies that I think inform what we're here about today. There'll be a few that I'm going to mention that are published experimental and quasi-experimental designs, and then a few more that are based on program evaluation data, mostly studies that are published, but I'll also share some unpublished data with you. And then finally, I'll talk a bit about the limitations in looking at nutrition education that we always face in terms of whether it really works or not. So this is a definition. It's an old definition from 1995. It's been adjusted some by Dr. Contento, and many of us across the country have accepted her more current definition. But I'm staying with this one for today because I think it's a little more relevant. It's any set of learning experiences designed to facilitate the voluntary adoption of eating and other nutrition-related behaviors conducive to health and well-being. My focus today is going to be on direct nutrition education that includes face-to-face interaction with participants. As you just heard, most of the WIC education is done in person. And a lot of that is true for the other programs I'll be talking about as well. And we'll be looking at studies that have reported change in nutrition-related behaviors. As I'm sure you know, there are very few studies that are published that don't report some positive changes, although you'll see among these studies, a few instances where no significant differences were found with nutrition education. So does nutrition education produce behavior change? Dr. Contento and colleagues published an extensive review in the Journal of Nutrition Education in 1995. They reviewed 227 studies, and their conclusion was that nutrition education works in that it is a significant factor in improving dietary practices when behavior change is set as the goal and educational strategies are designed with that as a purpose. And I think we want to remember that as we go through my presentation today, and I'll come back to that at the end. Most WIC reports in their review were in fact for the total WIC program. As Raphael said in his question, it's difficult at times to separate out what's happening in the program from the food package. There were 5 studies that they reviewed that investigated direct nutrition education among pregnant women enrolled in WIC. One of those found no results. It was brochures mailed to the home of participants. I think it actually did show some change in knowledge, but no change in practices. These 4 studies, they're old studies. They all did, in fact, show some change. The first one, a very old study now, found some changes in maternal diet quality. The others all focused on breastfeeding promotion and all found with pretty intensive engagement with participants, they all found an increase in breastfeeding duration. As you see, one was with a lactation consultant, one had postpartum contact versus none, but also, or the postpartum contact included hospital visits, phone calls, group support class, kind of the whole schmear. And then finally, there was one that had to do with a motivational video, peer counseling. Either of those, both of those together, or none. They found no differences among the 3 intervention groups, but all had increased breastfeeding duration as compared to the control. Okay, so their summary was that nutrition education works if you use systematic behavioral change processes, if you provide interpersonal and personalized counseling and education, if you include active participation by participants in learning, if you incorporate some social support, and if you use an empowerment approach that engages people in their own behavior change. So what I want to do today is look at the other programs along with WIC, SNAP-Ed and EFNEP. So SNAP-Ed is Supplemental Nutrition Assistance Program Education. It's the education arm of the SNAP program, previously called food stamps. Still feel like I have to say that sometimes. And EFNEP is Expanded Food Nutrition Education Program. EFNEP is the oldest of these programs. It, as you'll see in a minute, I'm going to compare these, provides only nutrition education. But they all do provide nutrition education with and without food assistance. And they come out of these 2 separate agencies within USDA. So if we look here, we have WIC versus SNAP-Ed versus EFNEP, and I want to point you to the food assistance because, as you well know, food assistance occurs for all participants of WIC. That is not necessarily true of SNAP-Ed. It is a part of the SNAP program, but it is not delivered in conjunction with food assistance. So, in fact, if you look 2 lines down there, you'll see that only about 2/3 of SNAP-Ed participants are actually participate in food assistance programs of one or another. And in EFNEP, it's actually about 3/4, even though that is strictly a nutrition education program. Otherwise, you see that the programs are not terribly dissimilar. Even in SNAP, with its 130 federal poverty level for SNAP benefits. The participants in SNAP-Ed actually are similar to WIC. And EFNEP is just low-income families and youth, but in fact, we sort of target 185. So they're pretty similar. All right, and here is the national program guidelines for nutrition education in these different programs. They all focus on the dietary guidelines. You'll see that they all include in-person nutrition education. EFNEP is investigating other forms at this point, but we're a little behind the curve, perhaps. The other two programs have other forms of nutrition education as well. The dose varies, as you can see. I would suggest that it's at least if you look at dose per 6 months, it's greatest in EFNEP. It varies tremendously in SNAP-Ed, and you know the dose in WIC. The educators are not that different. Always paraprofessionals in EFNEP, but professionals and paraprofessionals in the other two programs. And at in the bottom row, you have the evaluation. And what I want to point out there is that WIC has health data, which we don't have in the other two programs. The advantage of EFNEP is that we have a long-standing national evaluation system. So we do have some national data, which I'll talk about near the end today. Okay, so here are 3 studies that I selected to talk about that are either randomized controlled trials or quasi-experimental studies. The first one is by Joanne Ikeda from California. It's from 2002. And the reason I wanted to include this study in particular is that it's an example of how targeting programs is important. And Dr. Berman talked about that at the beginning, that it's important for programs to be culturally relevant. There are many studies in the literature that look at one intervention versus another. And that doesn't really tell you if nutrition education in and of itself is effective. It tells you that one's more effective than the other. And in this case, actually, they didn't really even look at one intervention versus another, but they did find in these immigrant women who were non-English speaking that delivering with paraprofessional educators who were culturally similar and an intervention that was designed for this population, they did see from 24-hour recalls improvement in dietary intake. The second study is in SNAP-Ed, and it was a randomized controlled trial using a delayed intervention as the control group. This is very common in these kinds of studies because we don't want to deny services to participants who might otherwise benefit. And you see here that they saw an improvement in food security and food insufficiency with this particular intervention. And then finally, a study that we did in New York City pretty recently was a randomized controlled trial, again with a delayed intervention group. We measured outcomes at baseline at 8 weeks and 16 weeks. And so the what we called the immediate intervention group, the one that received the intervention first, we had an 8-week period that was, you know, in medium term longitudinal, if you will. And we found, as compared to baseline, we found that the behaviors were retained for that long. So here you see the different behaviors that we looked at. The bottom one probably should be labeled food insufficiency rather than, or food sufficiency rather than food security. That sort of slipped by me when this slide was being prepared. So we saw increases in diet quality and food resource management skills and practices and in food safety, and those were retained. So the top solid lines show you the period with no intervention after intervention, and then the dotted lines show you the delayed intervention. we saw no difference in food sufficiency. Okay, so now I want to spend some time talking about practice-based evidence. I was saying earlier before we started this morning that I decided to spend some time on this because I think a lot can be learned from what's actually happening in the field. Although when we're looking at pre-post data with no comparison group, these are not, and the way they're collected, these are not research quality data, but there's a fair amount of information here that I think is relevant in practice. So we'll look at a WIC study, a SNAP-Ed study that's quite interesting because it compares the impact on participants receiving SNAP versus those not receiving SNAP. And then 2 studies with longitudinal data, and finally 3 EFNEP economic studies. So the first one is from California. It's in WIC. Oops, sorry. It's a statewide random sample, so it's fairly large with an N of about 3,000. What you see here, the intervention, they had 3 different intervention components, 3 different lessons, if you will, that were delivered across the state over 6 months. So every participant should have gotten at least 2 of those. And their results were obtained via phone interviews at baseline and 6 months later. And you can see some variation in results, actually. The participant reported self and family consumption showed an increase in fruit, vegetables, and whole grains, and an improvement in milk choices. However, in self-reported food frequency in the past week, there were no significant changes in fruit and vegetables. There was a decrease in juice, which might be considered a positive change or not, depending on your stance on that. Okay, and then also in California, through the UC CalFresh program, it's a SNAP-Ed program through Cooperative Extension in California. Again, a very large sample size. They had 4 classes focusing on nutrition and food resource management. The thing that is very interesting here is that they did pre-post and they compared behaviors with and without SNAP benefits. Now, they found an improvement in resource management behaviors. However, there was no impact of SNAP. So with or without SNAP, the improvement in behaviors was about the same. However, when they did a multivariate linear regression and looked at running out of food by the end of the month, or food sufficiency, food insufficiency, if you will, they found an interesting interaction between SNAP participation and post minus pre behavior change. So those on SNAP had improved food sufficiency as compared to those not on SNAP, and that interacted with their behavior change score. So to me, that's one of the few studies around that successfully shows that food assistance and nutrition education are important together. Okay, so let's look at some longitudinal evidence. This particular study is out of Wyoming. It looked at participants from 2005 to 2007. This 46% response rate refers to their follow-up. So they took everybody for whom they had pre and post data during 2005 to 2007, and then they did a 1 to 4 year follow-up male survey. So this last point on the longitudinal data varies a lot participant to participant. And here are their data. I'm sorry that's a little fuzzy. I just grabbed it out of their report, so it's not too crisp. But you can see there that there was an increase, and those were statistically significant from entry to exit, and there was no degradation in that over follow-up, 1 to 4 year follow-up. So that's the longest follow-up that I know in recent years. There's one in EFNEP that is often cited that was done many years ago. It was a dissertation. Actually, I've never seen it in the peer-reviewed published literature that showed retention of behavior change for 5 years. So, and there are others that have shown it for 3 years. But this is a recent study showing at least 1 to 4 years. Okay, and then we in New York State have some longitudinal evidence as well. This is not yet published. It is in the New York State SNAP-Ed. We did pre to post in person, and then a random digit dial for all of those participants who had completed the SNAP-Ed series of at least 6 sessions, and we called them basically using a random digit dial. This was done in 3 geographic regions of the state. Those of you who know New York State know that it's pretty different. And so we did it in the capital region around Albany, we did it in New York City, and we did it on Long Island. So pretty dissimilar regions of the state. We did pre to post in person, and then a 3-month and a 6-month phone survey follow-up. So you see, we also did a random digit dial of a comparison group that had similar income and but was not involved in SNAP-Ed. And so you won't see the data for that here on the slide, but I can tell you that the comparison group data were at about 3.3, just above 3.3 there, so right about the same as these 3 regional groups. So that was done just to show that our SNAP-Ed population doesn't differ from the general low-income population that would qualify for this program. And so again, what you see, some differences, but not statistically significant among regions. And you see that it increases, their behaviors increase post-education and are retained 3 and 6 months out. This is the same population. I just included this slide to show you one particular sub-data set, if you will. And this is a report of participants who offered fruit and vegetables to their family. And so you can see that the results are pretty similar. They're a little different for one region there, but not statistically different. Okay, and then what about cost-benefit studies in EFNEP? We have a few different approaches. I'm going to tell you about a study that's getting a little dated now, but it's a really nicely done study looking at savings in food costs after EFNEP education, or with EFNEP education. And then several studies looking at health benefits. And what I want to say about these points 2 and 3, particularly point 2, I guess. The first study, and I'm not going to report on this, but the first study was done in Virginia, and then their study has been replicated a number of different places. The results have not been too dissimilar. However, we replicated it, and I will show you our data, except that we changed the assumptions pretty dramatically because we felt like in that first study that some of the assumptions they made simply didn't hold water. So, for example, they assumed that if participants at exit, not as compared to entry, but at exit, were consuming 2 servings of dairy a day, that they would never have osteoporosis. They did not take into account genetics, they did not take into account any estimate for physical activity, nor did they take into account what the participants had been doing at the beginning, at baseline. So we changed a lot of that, and our results went down rather dramatically, but I think they still show some benefit. So let's begin with the food cost study. This was done in Tennessee. It was done in just before the turn of the century, actually. And a fairly large sample size. It was a randomized control trial with 3 separate groups. Now, the interesting thing about this is that in order to control for the idea that if you're recording your food expenditures, that will have an impact on your food expenditures, they had 2 intervention groups, one of which recorded their food costs. They kept grocery store receipts and records of food expenditures for which they didn't have receipts. They had a second intervention group that reported retrospectively what they had spent, and then their comparison group or their control group reported it retrospectively. So there was not that contamination during the period of intervention. They found an increase in nutrition behaviors and diet, so that's not different from a lot of different studies that we have. They have found an improvement in food sufficiency. They found a savings in food costs of somewhere between $10 and $20 a month versus $5.50 more spent per month in the control group. The net present value for EFNEP was 147 to 696 when they did sensitivity analyses. Excuse me. And in the control group was a negative value of 272 to 303. And what they did here, I mentioned this study that showed that behavior was retained for at least 5 years. There are 2 other studies that show 3 years, and so they projected for net present value, they projected savings over 5 years, and included in the sensitivity analysis, they did 3 to 5 years, as well as some other adjustments in the sensitivity analysis. Okay, and then this is the savings in healthcare costs that we did. This was our upgrading, if you will, of the original study. I worked with Don Kinkle, whom some of you may know at Cornell, who's a health economist, and he taught me to do cost-effectiveness analysis. It was a lot of fun. We found that there were 245 quality-adjusted life years saved at an estimated cost of $20,863 per QALY. Based on society's willingness to pay, and this is based on the Harvard inventory for each of the 10 different health conditions that we looked at, it was about 10 to 1. And I will tell you that the other cost-benefit studies, the original one was 10 to 1, but that was a strict cost-benefit. That wasn't cost-effectiveness using this methodology. And below that, you see the sensitivity analysis. We also did the strict benefit to cost as other studies had done, and we found less than $1 per dollar spent. This is actually not as disturbing to me as the EFNEP leader in New York State as you might think, or as some people might think, because in fact we only looked at a limited number of health outcomes, and this was an epidemiological approach. So we looked at the literature. It's all secondary data analysis that we pulled into our primary data. And we know that there are other things that EFNEP does. For example, there's a recent study that's been published out of Colorado looking at the impact on participants' quality of life. And if you actually go in and look at the National EFNEP website, what you will see is that one of the foci of the program is to improve participants' quality of life. We know that there are effects on children. We don't have a lot documented in that latter case, but we hear all kinds of anecdotal evidence about that. And so I'm not too worried. If we're approaching 1-to-1, hey, I think we're in good shape when we're looking at the limited number of outcomes there. Okay, and then finally, there's a recent study out of Virginia. George Davis is the senior author here, whom you may know. They took our approach and replicated it, but then they applied it across national EFNEP data. And this is one of the advantages of having, as I mentioned early on, of having our national data set. And the thing I really want to point out here is that there's quite a bit of variation. All but 3 states had less than 50,000 spent per quality adjusted life year, and this is, while perhaps debatable, sort of a level of accepted level of cost effectiveness. There were 3 states down there though, so there was a lot of variation across the states. Okay, so does nutrition education produce behavior change? Yes, but there are many variables. The effectiveness of the intervention as designed. Was it even effective to start with? What was the fidelity to the intervention when it was delivered? What is the skill of the educator? And I think that was mentioned by our previous speaker. And we know that from our own data in the study that I mentioned that was a randomized control trial that we did. We found about 10% of the outcomes being related to the particular educator involved. And the dose and the frequency of lessons. And so while dose and frequency of lessons have to do with the intervention as designed, I thought I would just quickly here show you some more unpublished data. You can see here, based on, in the second point is 6 lessons. It looks like I'm out of time. So you can see there is a dose response there. So I'm going to just say here very quickly at the end, there are limitations to the evidence. It's very difficult to assess dietary intake under the best of circumstances and related behaviors. There is social desirability in the responses, but alternatively, there is also this thing called response shift bias, which means that the intervention itself impacts the participant response, so that what we find is that often at post, the participant really understands what questions they're answering, whereas at pre, they thought they were doing better than they actually were. Okay, so there you go. Thank you so much.